make a couple modifications based on the discussion over the last 2 cycles that we've had. So our objectives for this session are to list the available buprenorphine containing preparations in the US, discuss some of the administration differences because they're not our traditional oral preparations, and then compare some of the pharmacokinetic parameters of these formulations. So what makes them different? All right. So we've got 2 different sets of buprenorphine preparations, one that are buprenorphine alone, and that's what's listed here. So our agents that we have that are buprenorphine alone that are approved for treatment of opioid dependence are the intradermal implant, our sublingual tablet, and then the long-acting injectable. There are a couple other agents listed here. Those have the indication for chronic pain. I was asked the last time to see if there was any cost information, so I was able to pull in some cost information. I just want to draw your attention to both the implant as well as the long-acting injection. These are the average wholesale prices of the implant and the injection, so that wouldn't cover the additional administration components. So if there's an office appointment to get the long-acting injectable shot, there would be additional cost associated with that, but this is just for the preparation itself for comparison. The second chart is for the buprenorphine naloxone preparation, so our combination preparations. These carry the indication for opioid dependence, and again, we have the costs that are listed there. The top buccal film, that one appears to be discontinued, although there is some cost information that was still available. So just from a reference perspective, I wanted to make sure that we included that. But we've got a couple different sublingual tablets, a sublingual film, and buccal films, or films that can be put just inside the cheek as well. My son was dancing on the other side of the computer, so I apologize. Slightly distracting. The other request that was made was to include information about morphine equivalents of buprenorphine. So this actually came from the Ohio Board of Pharmacy. They have a document that includes a whole bunch of oral morphine milligram equivalent conversions. So I selected the ones that just have the buprenorphine and the methadone, and they're here for your reference, but there is a link at the bottom of the slides that hopefully should be live. I'm not sure when it PDFs if it'll stay live, but you can go right there and it'll pull up the entire table for you. So administration, because we are looking at different types of preparations, I wanted to include some administration information. So for the implant, this is for maintenance treatment of patients who've been able to be maintained on relatively low doses of the transmucosal buprenorphine products. So they could be on buprenorphine alone or the combination, but they have to be on 8 milligrams or less a day for 3 months or longer. So at least 3 months to show that they're stable and they're able to be maintained on that dose. It is a surgical procedure where 4 rods, as you can see, are implanted into the upper arm in a fan distribution that opens toward the shoulder. These rods start delivering medication right away, and they remain in place and deliver medication for approximately 6 months. For our buccal administration, so this is going to be just inside the cheek. One of the reasons that we have the buprenorphine in these transmucosal preparations as opposed to just having an oral tablet or a capsule is because buprenorphine doesn't have great bioavailability. So we need a different way to get it into the body. So the buccal administration is a film that has kind of 2 layers. So one layer is what's called the backing layer. That's the layer that's going to be out toward the tongue and the rest of the mouth. It's not going to release medication through that. The microadhesive layer, that layer is actually going to deliver the medication. That's going to be the one that goes right up against the cheek. So patients are going to put that just inside their mouth, attach it to the buccal area. It should take no more than 5 seconds to get attached there, and it'll dissolve within 15 to 30 minutes. One of the advantages of the buccal administration is because it is on the cheek and not necessarily under the tongue, we don't see as many taste issues because that backing layer is there, it's not being released into the mouth, so they don't taste it nearly as much. And buprenorphine's been reported to have a really bitter taste. Just a couple instructions to remind the patients about, not to chew or swallow. If they do that, then they're not going to be able to absorb much from those buccal films. Washing and drying their hands, making sure their hands are dry. If their hands are wet as they're trying to apply that, it could actually get stuck to their fingers and start trying to deliver medication there. And that may not be quite as effective. You don't have as much blood flow to be able to get all of the medication in your fingertips as you do as inside your tongue. The other point to let them know is to try not to have them eat or drink anything until after that's fully dissolved. We don't want it accidentally becoming dislodged. So if they're doing a presentation like this morning and they have to speak a lot, that may not be the best time for them to administer it because as they're speaking, that may also dislodge the film. Our sublingual administration for both the tablet and the film. So these are gonna go right underneath the tongue, limited to 2, so 1 on either side. So as you can see in the picture on the right-hand side, they're putting that second tablet in. So if the dose requires more than 2 tablets, they would actually need to let those 2 dissolve and then add the next 1 or 2 tablets that they need to get their full dose. Again, no drinking or eating during administration, especially with the sublingual, because they could accidentally swallow the film, the tablet, and as those tablets are dissolving, it does take some time for them to dissolve. If they are eating or drinking, they may actually swallow some of the dissolved medication, and it can decrease the bioavailability by 1/3 to 1/2. And as we're gonna see in just a minute, we're not getting a lot of medication in, and if we further reduce that amount of medication, the patient definitely may start developing some symptoms of withdrawal. So just some instructions for the sublingual tablet or film. Again, clean, dry hands, making sure, especially with the films, that they're dry. Otherwise they can get stuck and it's difficult for them to get it where it needs to be underneath their tongue. They, however they're going to take their medication, it's important that they're doing that consistently. The film will dissolve relatively quickly. The tablet's going to take some time, and occasionally there can be a little bit of a grainy sensation for patients because once they've dissolved, some of the other ingredients in those tablets may stick around for a little period of time, but making sure as much get dissolved as possible so they're not crunching on it or swallowing those. Our last preparation is the subcutaneous injection, so our long-acting injection. So patients need to be on a transmucosal preparation for at least a week. So make sure they can be maintained on the buprenorphine for at least a week before they start the injection. There had been some discussion in a prior session about questioning whether that is going to remain. At this point, that still is in the dosing recommendations, that they are on it for at least a week, at least according to the what they have approved by the FDA, is that they still are recommending that. So it's an abdominal subcutaneous injection, 300 milligrams a month for the first 2 months, kind of as a loading dose. And then they can do either 100 or the 300 milligram monthly thereafter. It is a subcutaneous gel. So once it's injected into the subcutaneous tissue, it forms a deposit. That deposit will slowly release the medication over the course of the month. There have been reports that patients can feel the deposit even after the month has passed, excuse me. And it may just take some time for the body to break that down. So after the month, most of the buprenorphine has been released, but the actual delivery mechanism of that gel, that deposit, may take some time for the body to break down. There was a request at the last session to also look at some of the adverse effect changes and differences between preparations. So I went to the prescribing information. If you look at the tertiary literature, so things like UpToDate or Micromedics or Lexicomp, all of the buprenorphine products are combined together. So I wanted to look at them differently. So I did pull their prescribing information. So these were the reported adverse effects that happened in more than 10% of the patients, according to the prescribing information for the buprenorphine and the buprenorphine naloxone preparations. So as you can see, for the most part, the mono product and the combination product were similarly tolerated. They really had kind of the same adverse effects in similar percentages. Headache being one that was reported, withdrawal syndrome also being another, recognizing that in a number of the trials, there were patients that were just initiating some of these medications. So that may have been a result of the withdrawal itself and maybe not necessarily from the buprenorphine or naloxone. So overall, generally well tolerated. The Sublocade and the Zubsolv, they did not report the adverse effects other than the ones that are listed here, because they must have occurred at less than 2% of the patients in those clinical trials. So last sections on our pharmacokinetics and looking at how these differ. So for the implant, as I mentioned, they get surgically implanted and it starts releasing right away. It can achieve peak concentrations of buprenorphine after 12 hours, so 12 hours following the insertion. And patients are generally thought to be at steady state, so their concentrations of what's being delivered and what's being eliminated have kind of leveled out about a month in. Those concentrations can be maintained for 20 more weeks, and it is equivalent to about that 8 milligrams a day. So if patients need a higher dose, this would not be a good option for them. And it tends to be something that's not utilized incredibly commonly because coverage also tends to be problematic. In looking at our transmucosal products, which tend to be the most commonly utilized, time to peak in general, these are going to have peak concentrations between an hour, 2 hours, up to 3 hours after the medication has been administered. So the effect would be felt relatively quickly thereafter, so they're not going to have to wait for a long period of time. Half-life is going to be about a day. So as we're making any changes, it'll be about 5 days and the patient will be at a new steady state. So that would be the best time to kind of check in and see if there are side effects and if the new dose is still able to maintain their symptoms. From a bioavailability standpoint, I alluded to this earlier, we have pretty significant differences. So more of the dose in the buccal film is delivered compared to the sublingual film and the sublingual tablets. With the sublingual tablets, it does take some additional time, so it is possible that more of that dose gets swallowed. So as you'll see, we kind of have to use higher doses of those sublingual tablets to get the same concentrations for patients. This came from the prescribing information for the buprenorphine naloxone products. And as you can see, which really shouldn't be a surprise, the film has better bioavailability. We get higher concentrations from that, the sublingual film, and then the buccal film compared to those sublingual tablets. We just are able to get those higher concentrations. Comparing the two films together, the buccal film tends to achieve some of those higher concentrations. It doesn't mean we can't use the sublingual tablets, but just if we are moving in between formulations, we may need to dose adjust a little bit more significantly. And that's what you'll see here. So from the sublingual tablets to those buccal films, you see almost a halving of the dose to achieve equal concentrations to be able to control patient symptoms. And we do have at least one of the sublingual tablets that was formulated specifically to try to increase the bioavailability. That's the Zubsolv. That's why I pulled that in from the adverse effect standpoint. So it's manufactured a little bit differently. They use a dry mixing and direct compression procedure, and that actually results in tablets that are lighter and dissolve significantly faster than some of the traditional sublingual tablets. That gives us higher bioavailability, and therefore they can use lower doses of it because the patient's able to absorb more. Finally, for our subcutaneous injection, so we are able to sustain relatively high concentrations of buprenorphine with these long-acting injections. So unlike the implant, which was only able to deliver that 8 milligrams daily, the subblockade, so to orient you to this, so it's average concentrations when a patient's at steady state, the maximum and those minimum concentrations. We're just gonna focus on the average, that top line. So the Subutex is our buprenorphine monoproduct. Patients who are at steady state at 12 milligrams daily or 24 milligrams daily, you see their average concentrations listed there. When the patients were on subblockade and then maintained on the 100 milligrams monthly dose, you can see that the average concentration that they're achieving is even a little bit higher than what those 24 milligram a day sublingual patients were receiving. So these injections appear to be able to maintain patients that require higher daily doses for a longer period of time. We have heard some reports about patients having symptoms come back, especially at the end of the dosing interval. So in that 3rd and 4th week, just before they get their next injection, that they are getting some breakthrough symptoms. So I did look for some additional pharmacokinetic data. There is not much that's available at this time. I was able to find this. I pulled this right from the Subblockade website, and the link is there at the bottom. And I kind of wanted to draw your attention to some of the outliers. So on the y-axis, we have the buprenorphine concentrations, and on the x-axis, we have the number of days that they've been on treatment. So the first one goes to 200 days, and the second one goes to 400 days. So that red line here in the middle, the 2 nanograms per milliliter, that's what they were hoping to essentially achieve, like as the minimum concentration to make sure that patients were well controlled. As you can see, even early in therapy, it may take some time for patients to get up to that 2 milligram time frame. But once they're on those monthly injections, there tend to be patients that stay right down there. There was not a subgroup analysis done, but there likely are going to be a handful of those patients that are running right along there. And if they're barely at the 2 nanogram per ml or just underneath that, then it wouldn't be a surprise at the end of their dosing interval that they have dipped down. So I will continue to look for additional information, but it is new enough that we are just starting to collect some of this, and we don't have too much at this point. But that is the formulations of buprenorphine. I am going to stop and turn it back over.